Hi guys, today's section is all about HIV. As you all know, HIV infection remains among the most important infectious diseases worldwide. Although the epidemic has changed significantly over the years, traditional obstacles to successful care remain, such as prevention, early diagnosis, stigma, and public perception linkage to care, retention in care, and adherence to antiretroviral therapy. Right? Anyway, let us move to the definition for HIV. Human immunodeficiency virus type 1 is a retrovirus that predominantly infects lymphocytes that bear the CD4 surface protein as well as co-receptors belonging to the chemokine receptor family, that is CCR5 or CXCR4, and causes acute immunodeficiency syndrome AIDS. This definition implies that AIDS is the name given to a group of disorders related to immunodeficiency produced as a result of the infection by the human immunodeficiency virus HIV. So, this syndrome was first described in 1981 in Los Angeles in male homosexuals. In a short span of 24 years, it has spread all across the globe, affecting various spheres of human life. So, AIDS is the final consequence of various changes that take place in the immune status of the individual and is characterized by the occurrence of opportunistic infections and specific malignancies. So, this human immunodeficiency virus, targets and alters the immune system and increasing the risk and impact of other infections and diseases. Without treatment, the infection might progress to an advanced disease stage, which is called as AIDS. The major cause for this AIDS is the HIV, right? So there are two types of HIV virus, HIV 1 and HIV 2. These retroviruses are transmitted primarily by sexual contact and by contact with contaminated blood or blood products. Now let us see the classification for HIV. The Centers for Disease Control (CDC) classification is based on the CD4 count and the presence of AIDS associated conditions. Diagnosis of AIDS is made on the basis of CD4 cell count 200, CD4%, 14%, or development of one of the 25 AIDS defining conditions. So it is clearly defined in the MMWR 1992 41 section. Let us look at the Centers for Disease Control and Prevention 1993 revised classification system for HIV infection in adults and AIDS surveillance case definition. You can see the CD4 plus T cell categories, their absolute number and percentage as well. So normally the CD4 count ranges from 500 to 1600 cells per microliter or 40% to 70% of lymphocytes. So what is CD4 cells? CD4 cells are nothing but the WBCs that play an important role in the immune system, right? Our CD4 cell count gives us an indication of the health of our immune system, our body's natural defense system against pathogens, infections and illness. CD4 cells sometimes also called T cells or T lymphocytes or helper cells. Okay. So here you can see if the CD4 plus T cell category is more than or equal to 500 cells per microliter, or it's more than or equal to 29%, then we can suspect A1 asymptomatic acute HIV or PGL. Okay, as well as it can be either symptomatic not A or C conditions or AIDS indicator conditions such as C1. And if CD4 plus T cell category is in between 200 to 499 cells per microliter or 14 to 28% lymphocytes, then it can be A2 asymptomatic acute HIV or B2 symptomatic not A or C condition or C2 AIDS indicator conditions. And if the CD4 plus T cell category is less than 200 cells per microliter or less than 14% lymphocytes, can be A3, B3 and C3 asymptomatic acute HIV or symptomatic not A or C conditions or AIDS indicator conditions respectively. So here is the list of the AIDS indicator conditions such as candidiasis of bronchi, trachea or lungs, candidiasis esophageal, cervical cancer that is invasive, and coccidioidomycosis disseminated or extrapulmonary cryptococcus, extrapulmonary cryptosporidiosis, chronic intestinal, its duration can be more than 1 month, cytomegalovirus disease other than liver, spleen or nodes, cytomegalovirus retinitis with loss of vision, encephalopathy, HIV related, herpes simplex, chronic ulcer which that can be more than 1 month, or bronchitis, pneumonitis or esophagitis, histoplasmosis which can be disseminated or extrapulmonary, then isosporiasis, chronic intestinal which lasts for more than 1 month, Kaposis sarcoma, lymphoma Burkitt's, lymphoma immunoblastic, lymphoma primary or brain, Mycobacterium avium complex or M. disseminated or extrapulmonary, Mycobacterium tuberculosis which can be affected at any site, that is pulmonary or extrapulmonary, Mycobacterium, other species or unidentified species, disseminated or extrapulmonary, pneumocystitis, cardiac pneumonia, pneumonia recurrent, progressive multifocal leucos encephalopathy, Salmonella septicemia which can be recurrent, then toxoplasmosis of brain, and finally wasting syndrome due to HIV. So these are the AIDS indicator conditions. So based upon this, AIDS is categorized by CDC. Now moving to epidemiology. HIV type 1 is common throughout the world. By the most recent estimates, over 34 million people worldwide are living with HIV or AIDS, with a significant burden of disease in sub-Saharan Africa. In the United States, you can see 1.3 million people are estimated to be infected with HIV, with 1/4 of these persons unaware of their infection. The CDC estimates that as many as 70% of the 50,000 new annual infections in the US are transmitted by persons who are unaware of their HIV status. Despite comprising only 14% of the population in the US, African Americans are disproportionately affected by HIV, accounting for nearly 44% of all new cases of HIV in this country. Hispanics are also disproportionately affected by HIV. Women comprise approximately 24% of the US epidemic. Men who have sex with men, that is MSM, remain the population most heavily affected by HIV in the US. Of all new HIV infections in 2009, 61% were MSM. And HIV type 2 is endemic to regions in West Africa. It is characterized by much slower progression to AIDS and resistance to non-nucleoside reverse transcriptase inhibitors, that is NNRTIs. Now let us see who is responsible for AIDS. So already we discussed, as I mentioned earlier, HIV is the culprit for AIDS. So it belongs to the family retroviruses and its subfamily is Lentivirinae. So it is a member of the Lentivirinae subfamily of retroviruses. So these lentiviruses are characterized by their indolent infectious cycle. There are two related but distinct types of HIV, that is HIV 1 and HIV 2. This HIV 2 found mostly in the Western Africa and consists of 6 distinct phylogenetic lineages which are designated as subtypes, that is clades A through F. Okay, so these are the subtypes of HIV 2. Whereas HIV 1 can also be categorized based on phylogeny. There are 3 groups of HIV 1 which are currently recognized. They are M, that's main, then new, that is N, new or non-M or non-O, then O, which is outlier. So these are the subtypes of HIV 1 virus. Among those subtypes, you can see there are 9 subtypes for M subtype HIV 1 virus. HIV 1, okay. So this can be A to D and F through H and J and K. Okay, so these are the 9 subtypes of HIV 1 group M, which are identified as A through D, F through H and J and K. But this HIV 1 subtype is primarily responsible for the epidemic, especially HIV 1 subtype B. Okay, so this one is primarily responsible for the epidemic in North America and Western Europe. Now, the origin of HIV is of considerable interest. The accumulated evidence suggests that HIV in humans was the result of a cross-species transmission, that is zoonosis, from primates infected with the simian immunodeficiency virus, that is SIV. SIV, okay, simian immunodeficiency virus. Anyway, the earliest non-human infection with HIV has been traced to Central Africa in 1959. So let us see how we can detect HIV and what are the surrogate markers that appear during the disease progression. So when HIV 1 infection is suspected, whether owing to symptoms or high risk behavior, it should be confirmed by laboratory methods. The most common method is ELISA, that is enzyme linked immunosorbent assay. So this detects antibodies against HIV 1. The ELISA test is both highly sensitive, that is more than 99%, and highly specific, that is more than 99%. But false positive results can occur in multiparous women, recent recipients of hepatitis B, HIV, influenza or rabies vaccine, and patients with multiple blood transfusion, liver disease and renal failure, or those on chronic hemodialysis. So, false results can occur in these populations. As well as false negative results may occur if the patient is newly infected and the test is performed before antibody production is adequate. So, the minimum time to develop antibodies is 3 to 4 weeks. So, what is the time for the development of antibodies? 3 to 4 weeks from initial exposure, with greater than 95% of the individuals developing antibodies after 6 months. So, the convenient methods for obtaining ELISA sample have been developed. So, that can be an oral collection device or over-the-counter home fingerstick blood collection test system or urine test. So the positive ELISA are repeated in duplicate, and if one or both tests are reactive, a confirmatory test is performed for final diagnosis. So the positive ELISA are repeated in duplicate, and if one or both tests are reactive, you can say that HIV is confirmed for final diagnosis. So, Western blot is the most commonly used confirmatory test, although an indirect immunofluorescence assay is also available. A reactive ELISA test and a positive confirmatory test indicates an established HIV infection. If the confirmatory test is indeterminate, the dilemma can be resolved by retesting the individual after 30 days or performing a viral load assay if the patient is at high risk or symptomatic. Once diagnosed, HIV disease is monitored primarily by two surrogate markers. What are they? Viral load and CD4 cell count. So, the viral load test quantifies the degree of viremia by measuring the amount of viral RNA, that is HIV RNA in the plasma, There exist several methods for determining HIV RNA, including reverse transcriptase coupled polymerase chain reaction, that is RT-PCR, then branched chain DNA, bDNA, and transcription mediated amplification, finally nucleic acid sequence based assay. Anyway, this RT-PCR and bDNA, that is transcriptase coupled polymerase chain reaction and branched chain DNA, are used more widely than the other techniques. Irrespective of the method used, viral load is reported as the number of viral RNA copies per milliliter. Each assay has its own lower limit of sensitivity to viral subtypes, and results can vary from one assay method to the other. Therefore, it is recommended that the same assay method be used consistently within patients, because HIV attacks and destroys cells bearing the CD4 receptor. The number of CD4 lymphocytes in the blood is a surrogate marker of disease progression. So, as we mentioned before, the normal adult CD4 lymphocyte count ranges from 500 to 1600 cells per microliter, or 40 to 70% of lymphocytes. Okay, so CD4 counts in children are age dependent, with younger children having higher CD4 counts. The depletion of CD4 cells has been associated with the development of opportunistic infections and other AIDS manifestations. Now, Let us see how this HIV is transmitted into the host. So, infection with HIV occurs through three primary modes, that is sexual intercourse, primarily irrespective of anal or vaginal intercourse, then perinatal, then parental. First of all, let us discuss about sexual route of transmission of HIV. So, as I mentioned just now, sexual intercourse primarily is the receptive of anal and vaginal intercourse is the most common method for transmission. So, this HIV can be found in semen as well as cervical secretions, and exposure to either of the body fluids may transmit the virus. No sexual act between individuals can be considered absolutely safe. In general, the probability of infection is increased when the index partner is in an advanced stage of disease. Also, the heterosexual transmission include those with ulcerative sexually transmitted diseases, individuals with multiple sex partners, then sexual partners of injection drug users. Okay, so these are the heterosexual transmission routes. Then coming to the risk of transmission. So this risk of transmission is elevated when women experience vaginal bleeding during intercourse. Individuals with genital ulcers such as from syphilis, chancroid or herpes are at a fourfold greatest risk of contracting HIV. Gonorrhea, chlamydia and trichomoniasis increase the risk 2 to 3-fold. And infections also can occur from artificial insemination with infected semen. So this is all about sexual route of transmission. Now coming to the parental transmission of HIV. So this broadly encompasses infections owing to contaminated blood exposure such as from needle sticks, intravenous injection with used needles, recipient of blood products or organ transplants. So this use of contaminated needles or other injection related paraphernalia by drug abusers has been the main cause of parental transmissions and currently accounts for a quarter of AIDS cases reported in the United States. And the third route is the the second route was parental transmission, and the third route is the perinatal infection. So this perinatal infection or vertical transmission is the common cause of pediatric HIV infection. Most infections occur during or near to the time of birth, and therefore treatment of the infected mother is important. The risk of mother to child transmission is approximately 25% in the absence of breastfeeding and antiretroviral therapy. Fact is that increase the likelihood of vertical transmission include prolonged rupture of the membranes, then chorioamnionitis, genital infections during pregnancy, preterm delivery, vaginal delivery, birth weight below 2,500 gram, illicit drug use during pregnancy, and a high maternal viral load. So, breastfeeding also can transmit HIV. So, this is all about the transmission of HIV. Now, you must have understood the route of transmission of HIV. That's all for today. The remaining we will discuss in the next section. Thank you.